I'd like to now ask Dr. Catherine Maiteki from currently the Ministry of Health, National Malaria Control Division in Uganda. Dr. Maiteki previously served as the trial manager for the START IPTP trial that was conducted by IDRC from 2014 to 2016. She's a public health physician with a wide range of experience in clinical research, and she's going to present to us on behalf of IDRC. So thank you, Dr.
Thank you. Thank you. Good afternoon. So let's move to the east, where the sun rises. It's a slightly different context from the west. Intermittent preventive treatment is recommended for high-risk groups, including pregnant women, infants, in high transmission areas, and as we've seen, children living in areas of seasonal transmission. In Uganda, we found that it has benefited school children. We had a study in Toro conducted by Joanne Tanankabira, and we found that IPT with DP reduced the incidence of malaria by 96% in those school children. So we thought that targeting IPT to school children may also benefit the community for the following reasons: that school children are important reservoirs of malaria parasites, so they are source for onward transmission. And if we can target them, then would probably reduce transmission in the communities where they live. So the primary objective of this trial was to evaluate the impact of IPTP for malaria in school children using monthly DP on indicators of malaria transmission at the community level. And we aim to test the hypothesis that malaria transmission as measured by parasite prevalence and EIR would be lower in communities surrounding the intervention schools compared to those surrounding the control schools. So this is the study area, and it's in eastern Uganda, right at the shores of Lake Victoria, and but the control schools are the purple dots, and the intervention schools are the triangles. So it was a cluster randomized trial, and we had 84 clusters. A cluster was defined as a primary school with its surrounding households, and 40 of those 84 clusters participated as well in the entomology survey. So the intervention was delivered between March and December 2019. So we set out to enroll just over 25,000 children on the register. We were able to screen 15,000, and 10,000 were treated with DP. In terms of implementing the intervention, we delivered 6 rounds of DP between July and December, and enrollment increased steadily, but the proportion of children who received DP varied by round. And I'll just mention that we, in particular, struggled during the holiday time, which was in September. So you'll note that this is enrolled, these received any, and these received 3. So we struggled a lot with getting children to take DP during the holidays. Now, we also struggled with enrollment. When we hit the ground at the time, we did a lot of work at the school, and we didn't touch the community. Unknown to us is that as soon as you touch the school, the community became very sensitive. So enrollment really dragged in round 1, 2, 3, and it's only when parents started seeing benefits and chatting along in communities that they started to bring in the children. So that picked up in month 4, 5, and 6. So in terms of evaluation, we had a final school survey that was in November to December. The primary outcome being parasite prevalence by microscopy. We recruited 1,000 children from across the 84 schools. 80% of the children from the intervention schools had received IPT and were included in the protocol analysis. So just as it was already noted, in Uganda, this is the scenario. Less than 40% of these children slept under an ITN the night prior to the survey. So when we hear 90, we need to really learn. So in these schools, IPT had a significant impact on the school children, as already mentioned. And you'll note this is the control school, the intervention school. Really huge drop there, both in terms of parasite prevalence and even looking at the gametocytemia. Then the children in the intervention schools were also less likely to report a history of fever. And those who reported a fever were less likely to be diagnosed with malaria, which was great. Looking at the final community survey that was conducted between Jan and April 15, the primary outcome, again, parasite prevalence by microscopy. We enrolled close to 9,000 children, and that's the age breakdown. And in the community, we had a better figure for bednet use the night prior to the survey. Looking at the results, the parasite prevalence was marginally lower in the community residents. Overall, this is the overall, 23 versus 19. Then when we did looking at the age bands, we still have it lower in the intervention arms, despite the fact that the result was not statistically significant. We did have a trend there. We also had an entomology survey that I mentioned from 40 clusters. We had 200 households in total, and this ran for a year from April 14 to April 15, and we sampled houses monthly, the primary outcome being EIR. So again, EIR was lower in the IPT arm, but not statistically significant. At baseline, the households were similar in terms of EIR. We can have this compared to this. Now, during the follow-up, EIR was lower in the intervention arm, and most especially when the intervention peaked. I already mentioned that we struggled to get the children in. And if you look here, this is the entire period, the control arm, the intervention arm. But when we look at October to December, we have a slightly better figure in terms of the difference. So in summary, despite the low coverage, the IPT intervention had a positive impact on the school children, and we see a good trend there in the community. Children in the intervention arms were significantly less likely to have parasitemia. We had a 4 versus 99, the 44 for the control, and the 9 for the intervention. Then community residents from intervention clusters were also less likely to have parasitemia, 23 compared to 19. Entomology survey results also support this trend. Being important reservoirs of malaria parasites, delivering IPT to school children would benefit the children, but may also reduce malaria transmission at the community level. So we do believe that school-based IPT could help intensify malaria control towards elimination and should be considered for policies and programs. So this last slide is just to acknowledge all the different players. The PI was Dr. Sarah Stedke. We had Professor Moses Kamia, Dr. Grant, Dr. Claire, Professor Chris Drakely, Professor Steve, Dr. Andrea. The study was funded by the Joint Global Health Trial Scheme, the ACT Consortium. We worked closely with the Ministry of Health and the communities. Would like to specifically thank the leaders and the communities and all the participants. It was not an easy study, and we couldn't have managed it without the support of the district leaders. Thank you.
I just wanted to ask a question about what you would think about this as a long-term policy, because if you're going to be giving school-age children monthly doses of an anti-malarial on a regular basis, the pressure towards evolution of drug resistance could be quite considerable. And do you want to just comment on the downsides of giving such widespread use of anti-malarials compared to the regular exposure of these children to drugs?
Okay.
Would you like to quickly address that, or should we address it at the end when we're all having our, that's another, like, these critical topics we'd like to save for discussion afterwards. If you have a few quick words you'd like to respond
We
with,
can,
you
we
can,
can
or we
address
can
it at the
discuss.
end, that's fine.
Okay. That's a great question, Stephen. We need time.
That's exactly what we are hoping. Those are exactly the kind of questions we're hoping to have, and we have quite a long discussion period at the end, so we can ask for other input from some of the other speakers as well.
Thanks for the presentation. I have a specific question. I think you mentioned the study was in Tororo district, and so I was wondering if in 2014 there was indoor residual spraying conducted in Tororo, which could, and if that was the case, it could have impacted the enrollment of the kids as well as the utilization of nets for those kids as well.
This study was in Jinja. It's another study that was in Toro, and we didn't have IRIS in Toro in 2014 or in Jinja at the time of this study.
So I have one quick question. I was wondering whether all of the doses for each round were observed, because I thought it was that you presented the number of doses per round for each round. So did you do DOT for each dose of each round?
Yes,
That's
we
great.
did.
My name is Shabani. I'm working with Jabaigo in Tanzania. Thank you for a nice presentation. I've seen at your results, you've said that malaria prevalence has not statistically decreased. Have you looked at the species that are circulating in your area? Speciation, did you do speciation?
We have mostly P. falciparum in Uganda.
Mostly. Okay.
Even in this trial, mostly P. falciparum.
Did you confirm by research or just assumption that we have mostly? Did you do some sort of laboratory experiments confirming that PF only? Because I've seen that not only in Uganda, even in Tanzania, we still have problem with malaria at school. So we think, and we assume that it's only PF, 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 PF. Have we gone further to do speciation and come up with tangible results, confirming that it's only PF or Ovale, Vivax, and not assuming?
It was only PF.
Oh.
I think I'm almost positively sure. We have speciation on this study.
Okay.
One more clarifying question. So what did you do during the holidays for the distribution of the drugs?
We collected the children from home and brought them to the school. We had an announcement some would come, but not every last child would come. So we had motorbikes moving back and forth between homes.
I have one more question just about the ITN use, and we can again discuss more the issue of school children and net use later, but I did want to ask you if you know what the household coverage of net use or the household coverage of bed nets in the area is.
At that time?
Yeah, at that time.
2014 was a period right after the universal coverage campaign, because we run those every 3 years. So we had one in 2013, 14, and then we had one in 17, 18. So I think that's one of the things that really disappoints us, that right there in 2014, April, December, you have such a low figure where you expect to have given nets out and have something at least better. Because when we give out nets, we're targeting to hit 85% in terms of coverage and use 75%. So right there, 40, you're almost halfway, and right in the year when you gave out the nets.